Good evening, everyone. It has been a while since we've had our Facebook live sessions, and I hope I'm finding all of y'all in the best of health. We are basically having our male infertility series. It is a Q&A series. And before we jump on to today's topic, let me quickly brief you and give you a recap of what have been spoken about. For those of you who are with us for the first time, I am Dr. Pallavi Kalgharki, fertility specialist and IVF consultant and gynecologist at Zenith Advanced Fertility Center. So, what we have been discussing is that when it comes to evaluating an infertile couple, the male partner evaluation is very important, especially because the incidence of male factor infertility has been rising, and also more in the urban population. So that is why we concluded that we started with the importance of that. Moving on, we got to understand that the primary investigation or the first basic investigation that is required for the male partner is a semen analysis, and the semen analysis is usually done with an abstinence period of minimum of 3 days and maximum of 5 days, just in case there is some abnormality or something that is not correct. We can repeat the analysis to confirm. Usually, male factor infertility does not come with any symptoms or signs, but other than the obvious fact that the couple is trying and is not able to conceive, other than that, there are no real important symptoms. Sometimes, maybe having sexual dysfunctions like erectile dysfunctions or ejaculatory issues could be associated with male infertility. I think we already briefly spoke about the causes of male infertility, and we will be brushing up on that today as well. So, won't talk much about it. Finally, I think a very important topic was discussed last session. It was about why would a hormonal evaluation be needed for the male partner, because we wouldn't do it in every male. We would do it only in selective cases. So we spoke about how FSH, LH, and testosterone are the primary important hormones, and maybe prolactin and thyroid also need to be done in, especially in cases of sexual dysfunction. Now, the good part is that we usually, our Facebook sessions, we record them and we post them back on our page, and they are available for all of you to listen anytime. I mean, you all can pick up any topic or any thing that you all want to listen to again. It is discussed a lot in detail. So, you all are free to go and listen back. And today's topic, again, is very interesting. So, let us assume that in a semen analysis, you get a report suggestive of no sperms or zero sperm count. So we are basically talking about that. That is what is called azoospermia, and we will be talking about that. And for that, we are calling upon our expert, Dr. Mamta Dighe. She is the director and chief IVF specialist at Zenith Advanced Fertility Center. And today she'll be answering all the questions we have related to azoospermia. Please let us invite Dr. Mamta on the screen.
Hello.
Hello. Good evening, Dr. Mamta.
Good
How are you
evening.
doing?
Good, good. Thank you, Pallavi. Good evening to everybody, all our listeners.
So it has been a long break, but we are in continuation with our male infertility series. I have already quickly brushed upon what all have you spoken about, what is the significance of a semen analysis, how often should it be done, what are the causes, and we also spoke about the hormonal profile that we discussed last time. So today's topic is basically, so let us say that um, in the semen analysis we get a report suggestive of zero count or no sperm count. In medical, this is what we say, but medically we would call it azoospermia. So, can you tell us what is azoospermia exactly, and how common is it in male infertility?
So, absence of sperms in the semen sample, complete absence of sperms in the semen sample is known as azoospermia. We have to make sure that we have looked at least two semen samples and that we have centrifuged this semen sample and examined the pellet to make sure that there are no sperms even in the pellet, in the sense that you have the liquid of the semen. So we generally check the liquefied semen sample, but if you find that there are no sperms in the semen sample, you have to centrifuge the sample and look at the pellet that remains to examine whether sperms are found in that pellet. If there are absolutely no sperms either in the semen sample or in the pellet that you have examined, then in such a case, we term this as azoospermia, or absence of sperms in the semen sample. Now, the incidence of azoospermia is that about 10% of infertile males, that is, when the infertility is contributed by the male factor, in under such cases, 10% of the times this male has azoospermia. And about 1% of all males, in the reproductive age group who are trying, will have azoospermia. So that is the incidence. So it is quite common in cases of infertility, especially when it comes from the male factor. So this is a very, very important factor which has to be evaluated and looked at.
So, how would you say? I mean, what would you say are the common causes? Whom can we expect would have azoospermia?
Um, See, one of the common causes could be like a chromosomal problem in the male, okay, like something like we say Klinefelter syndrome or some other chromosomal abnormalities, or there can be Y chromosome microdeletions. That means obviously the female chromosomal makeup is XX and the male is XY. So all the determinants of all this is present on the Y chromosome. So there are certain areas on the Y chromosomes that are important for the presence of sperms. So if you have deletions in on of these areas on the Y chromosome, again that can lead to absence of sperms in the male. So this becomes a chromosomal problem or a genetic problem which is present, and you can't really do anything to change this completely. So this is one of the causes. The second is if there has been a case of undescended testis. So the testis comes down from the inguinal region and then into the scrotal sac as the baby is born. So sometimes if babies are born, the male children are born with undescended testis, and if this is not picked up and not treated early on in life, again in such cases it can lead to azoospermia. If it is a case of very long standing large varicoceles, okay, so varicocele is a condition where the blood vessels which supply blood to the testis become dilated. So under such circumstances the blood gets stagnated there, and the oxidative stress on the testis and the production of sperms causes a decrease in the sperm count in such cases. Now, usually varicocele will just first lead to a problem in motility, then affect the count. But if it is a very large varicocele or a very long standing varicocele, then it sometimes can even be the cause of azoospermia. Any injury to the testis again can lead to azoospermia. Any other issues such as hormonal factors, if the male has been having a very long standing hypogonadism where the hormones coming from the brain don't affect the testis properly, it can lead to that. And a very important factor that I would like to stress is sometimes there is good amount of production of sperms from the testis, but the tubes that carry the sperms from the testis to the semen are blocked. These cases are known as obstructive azoospermia. So over here, the production of sperms is not hampered. The testis is normal. All the hormone production, etc., is going on well. It's just that because of an obstruction, these sperms are unable to come into the semen analysis. Sometimes there's complete absence of these tubes, that is called absent vas deferens. So these are some of the common conditions under which we get to see that there is azoospermia.
So that brings me to the next question. So say we get a semen analysis done. We uh, we check this. I mean, the first sample shows no count. The second sample also shows no count. We centrifuge it. We check the pellet. Again, we see that there is no sperm at all. So would you say that the next step? Okay, then the next step would be to do a hormonal profile. So, how can you? What I'm trying to get at is how do we come down to one cause? And once we figure that out, like you mentioned that there can be a blockage and there can be a non-obstructive cause. So there can be an obstructive cause and a non-obstructive cause. So how would you handle each situation? I mean, would there be a difference in the management of each situation?
Okay. So, see, the moment you come across and you have concluded properly that this is a case of azoospermia, the first step that you have to do is try and understand whether it is an obstructive azoospermia or a non obstructive azoospermia. Why? Because the prognosis for both is very different, right? In cases of obstructive azoospermia, you know that your chances of finding sperms is extremely high. In cases of non-obstructive azoospermia, sometimes you really have to struggle to find even very few sperms. So the first thing is diagnose what kind of azoospermia this is. Now, how will you diagnose? Two major things. One is to do a hormone analysis, and the second thing is to get a scrotal ultrasound or a scrotal Doppler done. And of course, examination of the male is also a very, very important factor. So, in case your hormone reports are completely normal, if you have a completely normal scrotal Doppler or ultrasound, this case, more often than not, would point to an obstruction, which means the testis is normal, the hormones are normal, but probably there is some obstruction. And of course, on examination, the testis is turgid, it is a normal size testis. You can feel all those parameters normal. Then again, it would be an obstructive azoospermia. Some of the times you can see a very engorged or a larger than expected epididymis. So epididymis is a small structure which is just placed above the testis. So what happens is that all the sperms get accumulated in the epididymis. So again, if you see a large epididymal head, again it could point to an obstructive azoospermia. Now, with the same investigations, if you see that there are abnormal parameters, if the FSH is very highly raised, testosterone is low, if the testes are small in size, if there is a very large varicocele, all these would probably point out to a non-obstructive azoospermia. And if that is the case, you would definitely do maybe a karyotype, which is a chromosome analysis, and a Y chromosome microdeletion on this patient. Now, why would you do that? Because there are different types of Y chromosome microdeletions. And if you get a certain type of Y chromosome microdeletion in the patient, then what has been observed is you will be able to prognosticate whether or not you will get sperms from the testis. So even before you subject this patient to any operative procedure, based on your Y chromosome microdeletion, you will be able to prognosticate whether this procedure will even really help this patient. So these are the tests that you would do, and you would come to a conclusion of whether it is obstructive or non-obstructive.
Okay. Uh, okay, so that makes sense. But you said something like procedure. So I don't want to scare our viewers here. Can you, in a very simple way, explain how do we get how do we get sperms from the testes? So um, I believe it's a very simple procedure, and it can be, I mean, it can be a simple procedure, and it can also need a higher surgery. But what is this concept of finding sperms from the testes? Can you just elaborate for our viewers in a very simple way?
Okay. Right. So before I go on to that, there are a couple of things that I want to tell the viewers. And I think these are some very important points because we see it happening very, very commonly. Many times when there is azoospermia, many people are told to go through a testicular biopsy to try and understand whether sperms are there and what kind of abnormality is present. Like sometimes you have, there are different types where you have only Sertoli only cell syndrome, you have maturation arrest, different types of histopathological, that is what you see under the microscope. So many times these patients go through a testicular biopsy where there are needle put in or a small tissue of the testis is taken just for examination or pathological examination. Now, it is very important to understand that anytime you touch the testis, and if you're going to find sperms in it, these sperms need to be frozen. So there really is no role of just doing a testicular biopsy for investigational purposes, for diagnosis. Generally, any kind of a biopsy or getting sperms from the testis should be a therapeutic procedure. That means these sperms should either be frozen, or that the testicular biopsy or the extraction of sperm should be done when the procedure of IVF is indicated. So what I'm trying to get at is just randomly doing testicular biopsies just to conclude what kind of a problem it is, or just to see whether there are sperms, makes no sense in today's kind of treatment methodology that we have. That's the first thing. The second thing is, if you have an obstructive azoospermia, you have two options: either to clear the obstruction and then see whether the sperms are able to come into the semen sample. So there are surgical methods where you can clear the obstruction. But because we are operating in very, 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 very minute and microscopic areas and tubules, sometimes the outcome of these surgeries may not really be very helpful. You have to wait for a very long time. And even after doing the procedure, many a times sperms are not found in the semen sample. And then again, we have to go and retrieve sperms from the testis. Okay, so these are the two things that I wanted to, tell the viewers about. Now, another very, very important point that I want to make, which usually gets overlooked in most of the places, is that if you have an obstructive azoospermia, which means that the sperms are actually accumulated in the testis and they're kind of just waiting to get out, all you have to do is just put a needle into the testis, aspirate, and you will get a lot of sperms available for use. This is called a testicular sperm aspiration. So you're just aspirating the sperms and they come out very easily. If you have a non-obstructive azoospermia, which means the testis itself is not producing sperms, you really cannot do a testicular sperm aspiration, because you can't blindly keep putting needles in when you don't know where is that area where you can find sperms. So TESA, or a testicular sperm aspiration, is not what we do in a non-obstructive azoospermia. So many times we have had so many patients who have done a testicular sperm aspiration for a non-obstructive azoospermia, not found sperms, and have been told that they only need to use donor sperms. Whereas when they come here and we do a microtessay, that is a microscopic testicular biopsy and extraction of sperms. We don't call it aspiration, we call extraction. Here, what is done is that there's a small cut which is taken on the testis. The tubules are looked at under great magnification. And the tubules, which feel dilated, which seem like the sperms will be there. So you look at areas where you think you will find sperms. You cannot just blindly keep sticking needles in because you don't know where the sperms are present. So you look at it under magnification. You look at the areas where you will be able to pick up these sperms, and then you take the sperms from there and then utilize those sperms for doing the ICSI procedure. So even though it is extraction of the sperms from the testis, in both cases, the procedure that is done for both is very different. It is very intricate and must be done very, very well in the first sitting under an operating microscope if it is a non-obstructive azoospermia. I think if there's anything that I can give back in today's talk, it is this. Just two things. One, please do not randomly do testicular biopsies, because the more you stick needles in, the more fibrosis is going to happen in the testis. That's the first point. And the second point is, please try and understand whether it's an obstructive or a non-obstructive azoospermia. And for a non-obstructive azoospermia, you can't just blindly stick a needle in. You need a microtessay for this patient.
Yes, actually, that is very important because just pricking needles or just taking the call of we need to do something surgically and kind of scaring the patient is a patient, when you tell them there is something that we are going to stick something in their testicles, I think that is scary enough already. So when doing it when absolutely indicated is so important. But whenever we speak about this testicular aspiration, a lot of our patients ask a very practical, I mean, for us it's such a natural thing, but they ask us, can we use these sperms for an IUI? And so what my next question is that it goes without saying that when we have a male factor infertility to this extent, IVF is the only option. I mean, stimulating the eggs and doing an ICSI procedure. So can you please tell us about that?
So, see, there are two things. A lot of maturation of the sperms that is happening happens as the sperm comes out of the testis, goes into the epididymis, and comes out of the vas. All the secretions that are coming from the male reproductive tract add to the maturity of the sperm that is happening. So only these sperms are able to go ahead and fertilize the oocyte by itself, because the motility of the sperm and its maturity or the differentiation happens during its process through the male genital tract. That is one important reason why we cannot use these sperms for an IUI, because there the sperms have to go and fertilize the egg by itself. So it does not have the kind of motility that is required and the differentiation that is required for the sperm to be able to go and fertilize the oocyte by itself. That is one. Second is, we don't have those numbers. When we take sperms from the testis, we get very few sperms, especially in non-obstructive azoospermia. So we can't really use those sperms to go ahead and do an IUI. In fact, we don't even do an IVF in these cases. So what do you mean by IVF? IVF is where we just leave the sperms around the egg in a petri dish when you do the IVF procedure. Whereas ICSI is a process where you take one egg and you take one sperm and you inject the sperm inside the oocyte. So most of the times when we take sperms from the testis, We are not even doing an IVF, we are doing an ICSI procedure. And these are the two main reasons. We don't have the numbers, and we don't have the motility and the differentiation that is required to for the sperm to go ahead and fertilize the egg by itself.
Yeah, so that is a very big clarification that the sperms that we retrieve from the testicles cannot be used for an IUI procedure, and we need to go ahead and do an ICSI. So, Dr. Mamta, can you tell us that what would be the success rate in such cycles, like taking the sperms, extracting them, and doing an ICSI? So, what would, and let us say there are no other factors involved, so, what would you say would be the success rate for such cycles?
So, if it is an obstructive azoospermia, the success rates are extremely good because it's just an obstruction. You're bypassing that and you're taking the sperms. These are good sperms and very highly, in a very good capacity of fertilizing and creating normal embryos, good embryos. So, the success rates are as good as in cases of, let's say, a tubal factor infertility or something like that, right? So, this is with obstructive azoospermia. If it is a non-obstructive azoospermia and the sperms are, we find very few sperms or extremely abnormal sperms, then here the success rate is slightly less compared to a tubal factor infertility, and the miscarriage rate is also slightly higher compared to a tubal. Most of the times we are looking at tubal factor infertility as a baseline, because in tubal factor infertility it is just the tubes that we are bypassing. So we know that the sperms, the eggs, the uterus, the three main factors that are required for a pregnancy in IVF, rest all of them are normal. So that is our baseline or our threshold for comparison. So if it is a non-obstructive azoospermia, then probably if you don't get the quality of sperms that is required, the chances could be about 10% lesser than a tubal factor infertility, and the miscarriage rate could be slightly more, but it does not change if you have an obstructive azoospermia.
Okay. Um, so, can azoospermia as such? I mean, is there any type of azoospermia that can actually be completely reversed or cured?
Any type, of course, if it is an obstructive azoospermia, it can be, because if you treat and you find that the whole obstruction has gone away, or if a male has had vasectomy, that means where as a family planning method, like we do a tubal ligation, that is, we block the tubes in females. Similarly, the vas deferens, which are the tubes that carry the sperms from the testis to the semen, those actually are ligated. So, if that is the case, then if you reverse the vasectomy, then most of the times the sperms will come back into the semen sample because it was done for a family planning. It means that this is a fertile man with good number of sperms available. So this is one case, whether it's obstruction or a vasectomy, where you can actually really help to, I can say, reverse the azoospermia.
Okay, okay. So let us. We spoke all about how to all the high fundu words and all the procedures. Let us go to the basic. Is there any? I mean, do lifestyle habits or any change in our in the lifestyle of a male, can it really improve azoospermia or this condition? I mean, okay, let me put it this way. What would you advise as a fertility specialist to the men to have to avoid this situation?
See, there are certain situations which will never get avoided. Like I said, if there is something in the chromosomes, etc. But if you have this slow insult on the testis, which is chronic, and that can be avoided, then this process of going from a low count, low motility to the counts falling further and ultimately resulting in azoospermia, that can be taken care of to a certain extent. And I think this is, I think one common thread that we are constantly talking about through our FB lives or through anything that we are talking about is take charge of your life. I really feel that we should be working not towards talking about IVF, but talking about how to prevent IVF or how to make sure that we maintain our fertility to the extent possible. So, lifestyle, smoking, a huge amount of laptop use, a lot of kind of extreme heat around the testes, nutrients, food, what you put into your body, all these factors are, I think, extremely important. We can't control global warming because we have reports saying that even a degree or a few degrees of increase in temperature has seen a huge drop in the semen count of mice, and all these tests have been done. So obviously global warming is going go on, it's going to increase. So there are some things we can't control, or maybe we can, we don't know, if from our side we can take care of whatever we can for pollution, etc., etc. But at least what we can in terms of our weight, our BMI, our nutrition, our sleeping habits, the exercise that we do, the supplements that we take. Many times, people going to the gym, etc., tend to take a lot of testosterone supplements that is actually going to push the male into a case of azoospermia over a long period of time. So, if we have our antenna up, then we can be aware. My second thing is that anybody who is worried or just wants to make sure everything is fine, you can always get a few basic tests done that will at least tell you where you are, and if there is a problem, it will at least save the time that could worsen the problem. So I think being aware and taking the right action at right time will go a long way in taking care of most of the problem.
That makes sense. It always you always start at home, right? So you always start from the moment you get up. You have to make conscious choices so that you do not land up in a situation which you have to invest in. I think the kind of investment that you do today to live a better life, it reduces your monetary investment later on. So
Yeah, very true.
that's what. So I think that was what we had today. Let me quickly just go through if there are any questions. Um, we have someone asking us about the causes, but I think uh, we've already gone through that. How what are the causes and how we diagnose. We spoke about obstructive, non-obstructive causes. I think that's about it. And thank you so much, Dr. Mamta. This I kind of had set up the mood about azoospermia and no sperms. It kind of sounds scary, right? When I think the one of the biggest challenges that we face when we tell a male or a couple that the husband has azoospermia is scary, because when you say no sperms, he starts looking, I mean, he starts wondering what next. So
Yeah, I think it's almost like a death sentence on reproduction, right? That there are no sperms. But
yeah,
it need not be that. It need
yeah.
not be that. With the right diagnosis, the action in right time, and being extremely careful with the choices that we make. Like I said, many times because of what we don't know, we end up doing some unnecessary things, and that could actually worsen the problem. If you do all these things many times, most of the times, we would be able to find sperms and still have own biological child through ART.
Yeah, absolutely, absolutely, and it really gave us a lot of understanding, and it's having less knowledge gives more fear, and you kind of give up before even starting to try. So that was it was a very informative session, and thank you so much for coming on and answering all our questions today. Um,
Thank you, Pallavi.
yeah.
Yeah, I hope we've been of some use to everybody and created some kind of awareness. And thank you. That's it. Have a wonderful weekend, everybody.
Same here. Thank you. Bye. Goodbye.